So a continuation of the supplementary exam 2022. And what I've seen with these questions is that like we already answered all these. We also did that. Like this one. This question in the 2022 exam, which one is that? It's this one. The question came just like this in the exam. And in the supplementary exam, they brought it exactly the same. This one here. And you can see it's 20 marks and it's exactly the same. So we actually already did this question. So it will be something very easy. Same way with this question. They brought it and they brought it again. The same way it is in the supplementary exam. That is the same way with, I think, also this one. So it's more a revision of what we already covered. Anyway, let's go through them. A 1-month-old girl was invested for ambiguous genitalia. The pregnancy and birth had been normal. The baby had gained weight and normally the baby had gained weight normally and had shown no signs of illness. Ambiguous genitalia were noted at birth. The clitoris was enlarged and there was partial fusion of the labia. An ultrasound scan showed the presence of a uterus. An XX karyotype was found in peripheral blood. Now remember, this is a female, so because of the XX karyotype. But then, being a baby, she has got an enlarged clitoris. So already we can start thinking. And then the biochemical test on plasma revealed the following. The electrolytes, sodium was 135, potassium was 4.3, cortisol 11 am cortisol was the 313. The normal am cortisol is 140 to 700. And the 11 p.m. cortisol is supposed to be 0 to 138. So you can see this one is like elevated for the 11 a.m. Testosterone is 6.6. The normal is supposed to be less than 1 for those that are prepubert like this girl. And then 8.4 to 30 for the adults male. And then less than 2.7 for the adult female. 17 hydroxy progesterone is a 356, of which the normal is supposed to be less than 6. Or the androstenedione 19.4, the normal is supposed to be less than 12. What is the diagnosis? Work it out in the steroid synthetic pathway. Anyone that can help us with the diagnosis for this one? So let me draw the pathway and then we can now use that. When you are making steroid hormones, what you start with is cholesterol. And cholesterol is first going to be converted into prognenolone. This guy is the derivative from where all the steroid hormones will come from, prognenolone. And then from this guy now you are going to form first progesterone. From progesterone, this guy is now going to take two pathways, the progesterone. Number one, it is going to be converted in what is known as 11-deoxycorticosterone. And then the same progesterone can go into another pathway and form, instead of 11, it is forming 17 hydroxyprogesterone. And then what is happening is that the 11 deoxycorticosterone is the one that we are going to later on convert and form aldosterone, which is our hormone responsible for salt balance. And then we have got the 17 hydroxyprogesterone that can as well be converted into 11 deoxycortisol. And then the 11 deoxycortisol can now be converted into cortisol, which is the stress hormone. And then what happens is that the 17 hydroxyprogesterone can also be converted into testosterone. So these are the three products: testosterone. These are the three many hormones that we are producing, steroid hormones. But of importance that we need to know for this question is that for you to be able to form aldosterone, there are two important enzymes that we not only aldosterone and cortisol. You know, they say this is salt, sugar, sex. These hormones that come from the adrenal gland: pars glomerulosa, pars reticularis, pars, which one is that? Like that, reticularis, fasciculata, and glomerulosa. So there is an enzyme at this step, both here and here, and that enzyme is known as 21 hydroxylase. And then there's also an enzyme at this point before you can form. Of course, you have some other products before you form these, but you are going to have another enzyme before you can actually form your aldosterone and your cortisol. That is your 11 hydroxylase. So what happens is, for some people, they are born and they don't have the enzyme 21 hydroxylase. So if you don't have 21 hydroxylase, it means that you're not going to form any aldosterone, you'll not form any cortisol. And just a decrease in cortisol is going to go and stimulate the anterior pituitary gland to start releasing adrenocorticotropic hormone. But then the thing is that even when adrenocorticotropin hormone increases, it will come and start stimulating the adrenal cortex to release cortisol. But then there's no enzyme to release cortisol, so cortisol still remains low. If you see cortisol starts to increase, it means that the adrenal gland is not that destroyed; it's still responding to adrenocorticotropic hormone. Or maybe there is just a deficiency of the enzyme, but it might be there a little. So what happens is that because we can't go into forming aldosterone and cortisol, it means that this guy here is going to accumulate. So one thing that you can use to diagnose this condition, which we call congenital adrenal hyperplasia, the adrenal gland is hyperplastic. And specifically the one that is due to 21 hydroxylase is what you are going to see is that this guy is going to be high. But if you, so what do you expect then if it is 17 hydroxyprogesterone is high? It means that it is going to take another pathway. You are going to start producing more the testosterone, and this will make the female to have male characteristics because of the male hormone testosterone. But if it is 11 hydroxylase, which is not normal, what you are going to see is that in blood you are going to have elevated levels of 11 deoxycorticosterone. And even when you are not forming aldosterone, because 11 deoxycorticosterone is a weak hormone, it is going to be taking back the sugar. So there is not going to be any problem when it comes to sugar concentration, because this guy is working like a aldosterone, though it is weak. And same, you are going to have this guy also in blood. So that is how you differentiate the adrenal hyperplasia that is due to 11 hydroxylase deficiency or to 21 hydroxylase deficiency. Okay, so we just said that when you are forming this steroid hormone, our first product here is progesterone. That can go and be converted into aldosterone and then can be converted into cortisol and testosterone. But for you to form aldosterone and cortisol, you need the enzyme 21 hydroxylase at this level. So if this enzyme is not there, it means that you can't form aldosterone and cortisol. The the product is going to divert and go into another pathway that is going to cause the production of testosterone. And so there's going to be an increase of this guy because you have got this, but it can't go down here. So it will just take this pathway. Same when you have got a deficiency of 11 hydroxylase, there is going to be deficiency of aldosterone and cortisol. But if it is 11 hydroxylase, you might still have normal salt concentration in the body because 11 deoxycholesterol is also acting as a weak hormone. There is, of course, another deficiency where, because you also have an enzyme at this place where there's going to be formation of testosterone. And if that enzyme is also deficient, is going to also lead to reduced testosterone. And so a male is going to have female characteristics. So we can go back now to our question. Now that we have said something, at least we can look at this. Stenedione is 19.4. The norm is supposed to be less than 12. 17 hydroxyprogesterone is 356. You can see the norm is supposed to be less than 6. That's very high. Testosterone is very high also. Cortisol is slightly high here for the 11 p.m. cortisol. Normally supposed to be low. And then you can see the electrolytes. The electrolytes 135. This is little, this is small, because the normal for sodium, the plasma sodium is supposed to be nearly 200, 195 or 185, in that range from 185 to 200. So the first question, what is the diagnosis? Anyone that can help? What is the diagnosis? Thank you so much. Congenital adrenal hyperplasia, but specifically due to which one? Because for the congenital adrenal hyperplasia, the when you have got low 11 hydroxylase, that is still congenital adrenal hyperplasia. When you have got low or deficiency 21 hydroxylase is still the same. So which one is deficient? So when we have got a low, when you have got a deficiency of 11 hydroxylase, the salt levels are going to be normal because this guy acts the same as aldosterone. But then the salt level for this question is low. So which one do we expect? 21. Thank you. So congenital adrenal hyperplasia due to 21 hydroxylase deficiency. Right. And then B, so when it is this one which is deficient, you are going to still have normal levels of salt because you still have this guy here which also acts like aldosterone. It is a weak hormone that can act like aldosterone to help in salt reabsorption. Right. And then B. Explain the reason for the overproduction of androgens. Hope is that okay? Okay. So one interesting thing here is that you see when we are making these hormones, here we need 17 hydroxylase when you are forming testosterone. So when you don't have 21 hydroxylase and 11 hydroxylase, those two only affects aldosterone and cortisol. So if you don't have that, you are going to have accumulation of this because it can't form cortisol. You also have a lot of this because it can't form aldosterone. So they will take the pathway that is available. And in that pathway, 17 hydroxylase is going to now form testosterone. But when we have got low testosterone, that would mean that we have got a deficiency of 17 hydroxylase because that's the one that forms the testosterone. Okay, okay. And then question C, would you expect the level of plasma adrenocorticotropic hormone to be elevated, decreased, or normal? Anyone that can help with that? We expect it to be elevated, right? Why? Comes from the hypothalamus. The hypothalamus, when it notices, so if there is a decrease in cortisol, instructions will come from the hypothalamus to stimulate the anterior pituitary gland. Anterior pituitary gland. Anterior pituitary gland is going to release adrenocorticotropic hormone. And this is going to stimulate now the adrenal gland to produce the hormone. So the hormones from the adrenal gland, if they are low, that leaves the inhibition because normally cortisol itself gives a negative feedback inhibiting the anterior pituitary gland from releasing ACTH when the hormone cortisol is already high. But when the hormone is low, when you have got low cortisol, this inhibition is going to be lifted, and that is going to stimulate the anterior pituitary to start releasing this in an attempt to increase the amount of cortisol, right? And then D is saying comment on the cortisol level. So we can see cortisol here. Anyone that can give a comment? So let's look at the number. We can see this is 313. This is 11 a.m. cortisol. It's a 313. The normal 11. Okay, this is p.m. I was even using p.m. So this is 11 a.m. That's a 313. And then you can see this is a 9 a.m. cortisol is supposed to be 140 to 70. And then by 11 p.m., can you see that it's dropping? 11 p.m., this is at night, right? There is a very low level of cortisol. So what we are saying is that cortisol is highest in the morning, and as we go in the day, it is decreasing. And by the time we are reaching night, it has decreased, and then it will increase now in the morning. So is this low, high, or normal? Yeah, it seems normal, isn't it? Like this is 11 a.m. At 9, the number is supposed to be 140 to 700. And then this is at 11. So 11, it wouldn't have dropped that much. If at 11 p.m., the normal is up to 138. So this is still seems because there's a difference. This is AM and then this is PM. So this is still looking normal. Yeah. And if it is normal, why should it be normal? Why is it normal? Because normally it is supposed to be low, isn't it? The cortisol is supposed to be low in this condition because we are not producing the hormone. Anyone that can help? Okay, so the to be more specific from literature, the thing is that cortisol was supposed to be low. It was supposed to be low and not within a normal range. Even when you can see there is an increase in the production of ACTH, even from the previous question or from answering, ACTH increases, but that increase in ACTH does not correlate to increase in cortisol because you don't have the enzyme to form cortisol. The only close thing that I came across to was saying the the adrenal gland is still partially responding to the ACTH. That is why you can still see it is within the normal range. Otherwise, it's supposed to be low. That's a normal thing in this. Is it necessary to treat this condition? Why? Anyone that can help? Is it necessary to treat this condition? And if it is, why? If not, why? So we are saying yes, it is necessary. Why? Looking at here, this enzyme is deficient. So, one thing, if you don't have 21 hydroxylase and you don't correct it, one thing is that there's going to be low levels of aldosterone. That is going to cause reduction in the serum salt. That leads to the hypokalemia. You have got low salt. Basically sodium is going to be low, it's not going to be absorbed, so hyponatremia and those. And then when you come to cortisol, because cortisol is going to decrease, it's going to lead to what is known as adrenal crisis. That is basically where you don't have cortisol, and cortisol is necessary in maintaining a normal blood pressure. So there's going to be a significant drop in BP. So that's the adrenal crisis. Hope that is okay. So that is E. Is it necessary to treat this condition? Why? Another problem here why you should treat it is because of we are looking at all the three hormones. Testosterone is going to increase, and that leads to what they call virilization. Virilization is where a female ends up having male characteristics. So if you detect it early, you can as well treat it early and it can be a bit better other than when you leave it to go like that. A female, no breasts, a female, no menstruation, all those male characteristics. And then so E, is it necessary to treat the condition? Yes. Why? We are trying to prevent a drop in the salt concentration or like hyponatremia, hypokalemia. The problem, especially sodium, so that we are preventing hyponatremia. The problem for that, we know if there is imbalance of salt, it can lead to a lot of problems like also arrhythmias and these other problems that come because of sodium deficiency. And then there's also going to be cortisol deficiency. And so we need to treat the condition because we want to prevent adrenal crisis. That is where you are going to have a drop in blood pressure because you don't have cortisol, enough cortisol. Another thing that you want to prevent, why you should treat the condition, is you want to at least reduce on the virilization. A female having male characteristics because of the increase in testosterone. So you can now start giving, now that will be answering the other question. So you'll be now giving drugs that can help elevate aldosterone, elevate cortisol, and then reduce the testosterone. All right. And then F is saying explain the principle of therapy in this disorder. We've basically said it. Anyone that can say it again, the principle of therapy, the current problem. So we can give glucocorticoids, And specifically, we can give hydrocortisone to replace cortisol that is low. So we are going to give hydrocortisone, which is a glucocorticoid like the cortisol. That is to replace the low cortisol. The importance of using this hydrocortisone to replace the low cortisol is that when it has increased in blood, it will also send an inhibitory effect on the anterior pituitary gland, and the anterior pituitary gland will stop producing adrenocorticotropic hormone. Because as long as you are producing this hormone, it will be stimulating the adrenal gland to increase in size. Because you are putting pressure on the adrenal gland to produce the hormone, but the gland is failing to produce the hormone. So it is going to start increasing in size. That's hyperplasia, increasing in size of the gland. Okay, I'm talking of size and hyperplasia. Hope we can differentiate them, but I'm meaning increasing. The gland is going to be becoming big. Specifically, it is hyperplasia, not hypertrophy. Hypertrophy is the big size, but the cells will be increasing to try to produce the hormone, that is hyperplasia. But then you don't have the enzyme. So even when the gland is increasing, the cells are increasing in number, the gland is becoming big, it will really do nothing. So you want to also suppress ACTH. And then you can also give mineralocorticoids. Mineralocorticoids, an example of a mineralocorticoid itself produced by the adrenal gland is aldosterone. Just think of mineral like the source, mineral salts. So you also do the mineralocorticoid replacement. You can use fludrocortisone, and that is going to help. Thank you so much. So, what advice are we going to give them? Knowing that the only way a child can have this condition is that both parents have contributed a gene, an allele to be specific, that is responsible for this condition because it is autosomal recessive. So, now that we know it is autosomal recessive, and the only way they can have the child can have is because the parents have the gene. So, what is the advice that we're going to give to the parents? Let's say capital R is dominant, small r is recessive. So the only way the child can have is like this because it is autosomal recessive. Both parents are carriers. So now that we know that they are carriers, so this is just as long as you have got a capital, it is going to be normal. So there is 25%, which is the small r, that any child born can have this condition. Please, it doesn't mean that when you have got four children, one is going to be sick. No, it just means that for every birth that is happening, the possibility of that each child having this condition is 25%. So it is possible that all the children born can have the condition, or all the children born can't have the condition, because this probability is for each child having the condition. So now that we know that there is a chance for each child having a condition, you can ask them to go for genetic counseling so that they can be talked about the possible risks that the child can have. And besides that, also, in case, let's say, they want to have a child, they've just refused totally, we can't stay without children, they want to have another child. There is the prenatal screening or diagnosis. Just while the child is in the womb, you want to screen the child to be able to see if the child or the fetus has got a condition. Early detection is going to help in early treatment, and that worsens the effects. And sometimes you might not be able to track or to see the problem while the fetus is inside or inside the womb. So what you can do is that even when the child is born, there is also still the screening after birth, immediately after birth. So, in other words, if they undergo genetic counseling, it will help in the doctors being able to follow up the case to make sure that in case the child born has got a condition, can be helped early enough. Hope that is okay. Can go to question 8. A 25-year-old woman has been on an oral contraceptive pill for 4 years, then stopped taking the pill. 13 months later, her periods had still not returned. A pregnancy test was negative. If you look at the hormones, prolactin is high, thyroid stimulating hormone is normal, free T4 is also normal, 9 a.m. plasma cortisol is also normal. What is the diagnosis? Anyone that can help? Thank you so much. So it is a condition of having high. Let's make sense of this. Look at this. The anterior pituitary gland produces six hormones. The anterior pituitary gland produces six hormones. And these hormones you have got prolactin, you have got adrenocorticotropic hormone that is going to stimulate the production of the same cortisol. You have growth hormone coming also from there. You also have androgens, luteinizing hormone and follicle stimulating hormone. Besides this, you also have thyroid stimulating hormone. So, when you have got a cancer or pituitary adenoma, it might be not malignant, just benign. You expect that prolactin should be high, cortisol should be high, the hormones, the luteinizing hormone and follicle stimulating hormone should also be high. Thyroid stimulating hormone should be high. So you expect also free T4 to be high. But then in this condition, it is only prolactin which is high. So it means that whatever malignancy that we have here is specific to the cells that produce prolactin, and those are lactotrophs. So we are saying the possible diagnosis for this condition is an hyperprolactinoma, a condition that produces high a, a lot of prolactin, hyperprolactinoma, specifically hyperprolactinoma that is due to prolac- prolactinoma. Now my statement is when, so this is I'm supposed to say hypoprolactinemia because you have got high prolactin that is due to prolactinoma. So we are basically having a prolactinoma. This is a pituitary adenoma that is specifically affecting the production of prolactin and not other hormones. Hyperprolactinemia due to a prolactinoma, or you can simply say prolactinoma. Which drug can cause a raised prolactin level? Thank you so much. We have got the antipsychotics. Anything else? The opioids also. Thank you so much. Anything more? Thank you so much. Yes. Anterior. So look at this structure here. Remember when you're talking about the dopamine pathways, we talked about four pathways, the nigrostriatal striatal. Specifically, I'm interested in this one. What is the name of this pathway where dopamine is produced from the hypothalamus to the anterior pituitary? It starts with a T. Thank you. The tubero infundibular pathway. You know that the pituitary gland specifically is coming from the hypothalamus, and it is held by this stalk, which we call the pituitary stalk or the infundibulum. So what happens that the hypothalamus produces dopamine. This dopamine is going to go on the specifically the anterior pituitary gland on the lactotrophs using the D2 receptor, and when it attaches there, it is going to suppress the production of prolactin. This is telling us that any drug that reduces dopamine is going to lift off the inhibition on the anterior pituitary gland from producing prolactin. And so prolactin is going to be high. Example of those conditions, we know in psychosis, dopamine is high for those positive symptoms. So what happens is that you need to reduce the dopamine. So the antipsychotic drugs, because they work by reducing the dopamine, they can cause this condition. Besides so those are dopamine antagonists. Besides those, also antiemetics, because when you go to the when you look at the pathway for vomiting pathway, dopamine also plays an important role in what is known as the chemoreceptor trigger zone. So when you want to prevent vomiting, you also give drugs that to inhibit dopamine in the chemoreceptor trigger zone. And so that also can result into prolactinemia. So antiemetics, for example, domperidone and the metoclopramide. You can also antihypertensives like verapamil and methyldopa. Those are also going to be able to lead to the same condition. Remember, uh, anyway, let me not mention much there. And then, so hypertensives also opioids. So just those drugs that are reducing dopamine, they are going to increase the production of prolactin. What is meant by the term stalk effect and how does it arise? Anyone that wants to help on that one? Thank you so much. Compression of the pituitary stalk. So that is how it arises. And then, so what is it itself? What is the effect after you've compressed on the pituitary stalk? Thank you so much. So it is in the stalk that we have got the tuberoinfantibular tract. So if you've compressed this stalk because maybe there is a mass or there is a pituitary malignancy or tumor, there's a compression on that. This dopamine is not going to flow from the hypothalamus to the anterior pituitary because it is not flowing. That is going to lift the inhibition on the anterior pituitary, and then prolactin is going to be produced again. So that is the stalk effect. MRI scan of the pituitary showed a small tumor. The prolactin level returned to normal and the menstrual cycle was restored after treatment with bromocriptine. What symptom of this condition did the patient not have? Remember, this condition is a condition of high prolactin. What did the patient not have? Anyone? If someone has got high levels of prolactin, what do we expect to happen? Thank you so much. So we expect them to start producing a lot of milk because prolactin causes the production of milk. But in this condition, it wasn't mentioned. So galactorrhea, I failed to pronounce this word. Hope it's like that. Galactorrhea, amenorrhea. Okay, that is it. So just the production, milk discharge from the breast wasn't seen because nothing has been mentioned for this question. So that is one thing that we always expect when someone has got high prolactin, but it wasn't there. How can the normal thyroid and cortisol result in this patient be reconciled with other abnormal findings? How can the normal thyroid and cortisol results in this patient be reconciled with other abnormal findings? What we are just saying is that look at this. These are normal, But then prolactin is not normal. How is that possible? How can you have abnormal prolactin and normal thyroid hormones and cortisol is normal? Is a pituitary adenoma that only secretes prolactin. So that is normal. This is supposed only to increase prolactin and not other hormones because it's only affecting the lactotrophs which produce prolactin. And then the last question, a 19-year-old male presents with 2-month history of weakness, fatigue, intermittent fever and pardon? Okay, so we have said D. It's possible they can be high prolactin and normal. The other hormones are normal because, by definition, a prolactinoma is a pituitary adenoma that is only producing prolactin. So the other hormones will still be normal. All right. A 19-year-old male presents with a 2-month history of weakness, fatigue, intermittent fever, and epistaxis. He was previously well with no history of illness. On examination, he is pale, febrile, hepatosplenomegaly, and gum hypertrophy. Full blood count shows a total white blood cell count of 1.15, you can say that's low. Hemoglobin 4.2, that's also low. Platelets is 24, you can see from the reference range, that's also low. Give an interpretation of the full blood count results. Anyone that can give us the interpretation? Which have, thank you so much. It summarizes everything, right? So give an interpretation of the full blood count. There is low white blood cell count, low red blood cell count, low platelets. So that is a pancytopenia. And then B, what is the term used to describe the total white cell count in this patient? Leukopenia, since it is low white blood cells. Okay. Give two causes of low total white cell count. Anything that can reduce the number of white blood cells. Aplastic anemia. What is aplastic anemia? Okay. Thank you so much. So since we've even said it is aplastic anemia, is it affecting other cells? All right. Any other condition that can result in a decrease in white blood cells? Thank you so much. Chemo. You are treating the body with these drugs and they end up destroying all the blood cells. So chemotherapy. Besides chemotherapy, anything else? Autoimmune disorders. Thank you so much. Autoimmune disorders, bone marrow failure, all those things can lead to a decrease in the white blood cells. What could the explanation be for the intermittent fever in this patient? Anyone? Why do we have fever? Why does this patient have fever? Thank you so much. The reduction in white blood cells decreases the immune response of the cells, and so they are susceptible to infections. Let's say they end up getting infection like malaria, which breaks down the white blood cell, the red blood cells also. So what could explain the epistaxis in this patient? Epistaxis is bleeding in the nose. Why is this patient bleeding? Thank you so much. So reduction in the platelets makes the patient to be more susceptible to bleeding, thrombocytopenia. And the problem is that that bleeding can also lead to intra disseminated intravascular coagulopathy because someone is bleeding very much because of low platelet count. Just that bleeding is going to activate the platelets, and then they'll start forming clots within the blood vessels, and those clots will be spreading throughout the body, disseminated intravascular coagulopathy. A bone marrow aspiration, BMA, and trypin biopsy are performed. The bone marrow aspiration is markedly hypercellular with predominancy of intermediate to large cells with a moderate cytoplasm with granules and Ur rods. Nuclei are of variable morphology with fine chromatin and prominent nucleoli. The trifine biopsy shows the same features. These cells express CD34, CD13, CD33, CD117, and are negative for TDT. Please, we need to take note. This is a marker for lymphoid cells, like the T cell leukemia and the B cell. What could explain the gum hypertrophy in this patient? So already from what we can see, we are identifying just using Oabo rods and these markers CD13, 33, and 17. These markers are specific for which condition? Thank you. Acute myeloid leukemia. It is not chronic because if it is chronic, we would have been looking for something else. What do we look for in chronic myeloid leukemia? Okay, there is what we call the Philadelphia chromosome, isn't it? So that is what you are trying to look for. And the is it B? What's that? BCLABR? Yes. So there is that gene that you look for. That is if it was chronic. So what could explain the gum hypertrophy in this patient since we are saying they have got acute myeloid leukemia? Why the hypertrophy of the gum? Thank you so much. So these same cells, these leukemic cells or these tumor cells are going to start infiltrating the gums. That is why there is hypertrophy. And then what is the nature of the cells described in the bone marrow aspiration report? Anyone? Look at these cells. These cells are hypercellular. They are large cells, moderate cytoplasm with granules. The nuclei are of variable morphology, fine chromatin, prominent nucleoli. What kind of cells are those? Thank you. So these are blast cells. They are immature cells. What is the definitive diagnosis in this patient? Acute myeloid leukemia. What further investigations would you request beyond what has already been provided? So what you've been provided here are markers, the CD markers and the TDT. There's also the bone marrow aspiration. What other further investigations can we carry out? So this condition also, thank you so much, karyotype. Anything else? So this condition is also can be genetic. So you also want to do cytogenetic analysis, cytogenetic analysis, and the cytogenetic analysis is you are trying to look at the abnormal chromosome. Besides the cytogenetic analysis, you also want to do some molecular analysis. Molecular analysis is not looking at the chromosome, but you are looking for the specific gene. So molecular studies and some genes for acute myeloid leukemia that you are going to see is the FLT3 gene. There's also what is known as NPM1, at least these. There's another one, GNMT3A. These are the specific genes that are implicated in acute myeloid leukemia. Besides that, you can as well do imaging like a CT scan. Actually, this condition, the acute myeloid leukemia, can also get to spread to other parts, specifically the central nervous system. It can go there. So, I want also to do a lumbar puncture to see if there is the involvement of the central nervous system. What are the treatment options for your diagnosis in 8 above? Anyone that can help? Thank you so much. Anything more? Okay. So, adding on what the doctor said, on the treatment options, you want to give a general supportive therapy to the patient. Okay. You can see in this question some problems. Okay. It's not really mentioned for this one, but you can deduce it from the. I wanted to connect with what is on top. If we are saying there is a low blood count, but hope that's a different question. So you want to do a general supportive therapy. Whatsoever that can be weak, whatsoever that they are complaining of, you want to help with that which they are complaining of. Let's say because we have got this is acute myeloid leukemia. What are you expecting? Maybe let's say they're having fevers. You want to help with that. If they're having any form of problems with weight, you want to help with that. So basically, supportive therapy. Besides that, because you have got cancerous cells here which might be spreading everywhere, you want to also do chemotherapy. And then you can as well do stem cell transplant in case the cells that are here are the stem cells themselves are affected. So you can do a stem cell therapy. So that is the basic thing about this. Let me just mention one thing in conclusion about acute myeloid leukemias. They can be classified in 7 different groups that we have to know. You have got those acute myeloid leukemias that have got recurrent genetic abnormalities, like the same abnormalities that we've talked about, which we've mentioned, like the LT3. That is number one. And those which have got genetic abnormalities, they've got a good prognosis. The second one is acute myeloid leukemia with myelodysplastic related changes. So here you are just going to be seeing different cells of different sizes and shapes in the bone marrow. That is I can write that myelodysplastic. So acute myeloid leukemia with myelodysplastic related changes. You also have those therapy related myeloid neoplasias. They call them therapy related acute myeloid leukemia. It's related to therapy. After treatment, someone ends up with a condition after, let's say, chemo or something like that. And then you also have other acute myeloid leukemias that are not specified. It's not related to genetics, not related to these other things. And then you also have the myeloid sarcoma. It is rare, and this one refers to disease that resembles a solid tumor, but it is composed of myeloid blast cells. That is a myeloid sarcoma. It's like a tumor, a solid tumor, but it has got a myeloid blast cells. It's also known as extramedullary leukemia or granulocytic sarcoma or chloroma. If you hear extramedullary leukemia, it is spreading, it has come from the bone marrow, it has now gone to the rest of the body. Actually, when you're performing therapy and you want to see if your therapy is well, it has worked, what you want to see is that there should be no extramedullary cells. They shouldn't have spread to other parts. So all those that have spread, they should be killed. Then it means that treatment is well. And then besides that, you want to have less than 5% blast cells. Okay. Another type is a myeloid proliferative related to Down syndrome. So people that have got Down syndrome are likely to have these acute myeloid leukemias. Some, so you classify them into two, those with have got Down syndrome. Sometimes they can just have a transient condition. Sometimes it is the actual acute myeloid leukemia. And then the last one is acute leukemia of ambiguous lineage. It has got mixed phenotype. You have got the lymphoid cells and also the myeloid cells. So it is mixed up. That is of ambiguous lineage. And that is it with this paper.